Good day and welcome to this lesson on the 4Ps. The previous 3 lessons were on how to use the partograph, how to fill in the partograph, and in this lesson we are going to discuss the 4Ps and how do you use the 4Ps in the interpretation of the partograph. And when we are doing the interpretation of the partograph in the following lesson, we will definitely come back to the 4Ps again. So when we interpret the partograph, we usually use the rule of the 4Ps, and the P stands for different aspects, namely the aspects of the uterine contractions, bowels, the aspects of the fetus, the passenger, the aspect of the birth canal, which includes the bony pelvis as well as the soft tissues, and that's the passage, and then aspects related to the woman, that will be the patient. Now we will discuss each one of these separately, and we will start with the passage. So if we talk about, in the passage we refer to the pelvis, the full bladder, and the cervix and the vagina, and we will discuss each one of them separately. So when we talk about the pelvis and look at the size of the pelvis and the engagement and descent of the fetal head and molding, which are all indicators of the movement of the fetus through the pelvis, we might say that the pelvis might be too small when we have the following evidence. When on abdominal examination, the fetal head is not engaged in the pelvis or is not engaging further in the pelvis. For example, if we find that 3/5 of the fetal head or more is above the brim of the pelvis, that might be an indication for us that there is CPD or cephalic pelvic disproportion. Also, if there's no improvement in the engagement through labor, and specifically when there are strong contractions. Also, when there's no progress in the descent of the head, which is going usually hand in hand with a lack of engagement of the fetal head. And then molding must always be regarded as a serious possible sign of cephalic pelvic disproportion, as we have said previously. A full bladder might cause obstruction and prevent engagement and descent of the fetal head because, as we also have previously said, and if we look at the anatomy and where the bladder sits, and specifically a full bladder during labor, it sits just above the symphysis pubis, so it will cause obstruction for the head to move into the pelvis. So, and that is why it's so very important that the bladder must be emptied every 2 hours. Abnormalities of the soft tissue, the cervix and the vagina, can also sometimes cause prolonged labor. For example, atresia of the vulva and atresia of the vagina, and also some septums or cysts in the vagina. Also, cervical stenosis or cervical myomata might also sometimes cause prolonged labor because it causes obstruction of labor. Then, when we look at the passenger, which is the fetus, we look at all these aspects of the fetus: the presentation, the position, the attitude, the application of the cervix, the large fetus, congenital abnormalities. Now, when we come to the interpretation of the partograph, I will come to again, how do we look at each one of these when we are interpreting the partograph? For example, if we look at presentation, certain presentations of the fetus might cause prolonged labor. For example, brow presentations, because there's a much bigger diameter of the fetal head that has to move through the pelvis. Or in the case of the breech is not as hard as the head, so application is not good. And we've said if application is not good, the contractions are not so good, and labor might be slower than in the case of a cephalic presentation. The position of the fetus might cause prolonged labor for different reasons. For example, in the case of an occipito-posterior position, we might have a longer labor because the fetal head is not well flexed, and with a larger diameter that presents, labor might be longer. Also, the posterior occiput needs to rotate so that the sagittal suture becomes in the AP diameter. So the occiput needs to rotate all the way from the posterior position to anterior or directly posterior, and that also might take a while and make labor a little bit longer. So it might be necessary for you to just revise the mechanism of labor of the occipito-posterior position again to understand what I'm talking about. When we look at the attitude of the fetal head, we refer to whether the fetal head is in flexion or extension in the uterus, and that determines the diameter of the fetal head that will present. So when the vertex presents and the head is in flexion and the baby is literally with his head chin on his chest, 9.5 centimeters the diameter that presents, while in a deflexed head, 11.5 centimeters the diameter, and in the case of the brow presentation, it's 13.5 centimeters. So it's obviously that the head with a 9.5 centimeters diameter will move through the pelvis easier than a head with a 11 or a 13.5 diameter, which will obviously move much slower and cause problems. Okay, in application, we have talked several times in the Partograph lessons about the application of the presenting part on the cervix and how important that is for the progress of labor. We have said that the better the presenting part fits on the cervix, so the better the application is, it causes a reflex reaction. We get the release of prostaglandins, which leads to better contractions. And then when there are better contractions, we get a better dilatation of the cervix, and labor just progresses much better and easier. And that brings us to the third P, which is contractions, the powers. The contractions obviously are very important for the progress of labor. If the contractions are not adequate or effective, labor might be prolonged. So when we look at the definition of inadequate contractions, we say it's contractions that last less than 40 seconds and or are fewer than 2 in 10 minutes. So the contractions, the duration of the contractions are not long enough, and the frequency of the contractions are not enough to make labor to progress. Or we might have adequate contractions. They might be long enough and they might be the frequency might be enough, but they are not effective, and there's no progress of labor without any signs of disproportion. So there's nothing that hinders the fetus to go through the pelvic channel, if I can call it like that, because there's no sign of CPD, but as I've said, the contractions are just not effective enough to make the fetus to move through the Okay, then we come to the fourth P, which is the patient, and every aspect of the patient will actually count under this P. I'm going to talk about specifically dehydration and ketoacidosis, pain and tension, and the maternal position. Also, it's under the patient, and the Partograph, it's very important to analyze the maternal vital signs because this will also give us a lot of information regarding dehydration and pain and the condition of the mother and progress of labor. So if we look at the first one, which is dehydration and ketoacidosis, restriction of food and drink during labor might result in dehydration and ketosis. Labor is quite hard work, And during labor, with all the muscle contractions of the uterus, it uses a lot of energy and therefore glucose. If the glucose is not being provided to the woman in the form of diet or glucose-rich fluids and maybe sweet things, during labor, the body will start to metabolize protein and fat stores to provide this energy. And we all know that ketoacidosis is the off-fall product of these fat stores that's been used for energy. Now, unfortunately, this dehydration and ketoacidosis have an influence on the uterine contractions, and it makes the uterine contractions ineffective, which then eventually cause prolonged labor. The second aspect here under the patient B is pain and tension. Now, I'm not going to elaborate on that. That's a very obvious one. Excessive pain also leads to fear, and it causes the secretion of catecholamines, which also cause irregular and ineffective uterine contractions. It also causes pain usually leads to fear and leads to tension, and that also leads to tension of the cervical muscles, which also might lead to a slow dilatation of the cervix. Now, under the third aspect here, under the P for patient, is mobility and the position of the patient during the first stage of labor, and that obviously plays an enormous role in the progress of labor, because mobility encourages engagement and descent of the presenting part because of gravity, and that contributes to the progress of labor. It also helps to distract the woman's attention from the discomfort and the pain of her contractions. And we've just in the previous slide, we have seen how what the effect of pain on the progress of labor is. Then also when the woman lies in a dorsal position, we get the pressure of the huge, large uterus on the big blood vessels, the aorta and the vena cava inferior, which decreases blood flow to the maternal heart, and then eventually also diminishes the blood flow to the uteroplacental area, and that might contribute then again to fetal distress. And the fetus is, as it is, a high risk to develop fetal distress in the case of prolonged labor. So definitely this can't also contribute, we can't allow this to also contribute to the development of fetal distress. Then positioning can also facilitate rotation of the fetal head in the case of some of the abnormal positions, for example, the posterior position, and it also promotes maternal comfort and decrease pain. For example, we know that in the case of a posterior, occipito-posterior position, the pressure of the big occipit posterior part of the head on the sacrum causes a lot of backache, back pain, and by the positioning the mother in different positions to take this pressure off the sacrum helps to relieve pain. For example, if the mother can stand in a all fours position, standing on her hands and her knees, that takes the pressure off the sacrum. And then in total, it relieves pain. I have the fetal heart here, not as part of the 4 Ps, but one almost wants to classify it under the passenger, because it also has an effect on the progress of labor, in the sense that prolonged labor might lead to fetal distress. And there are always 2 very important aspects of the fetal heart that's very important on the Partograph to assess, well, which will tell us that there is fetal distress developing or already present. We need to determine the fetal heart rate between contractions, during and between contractions, and also the presence of decelerations and the relation thereof to the contractions before and after contractions are the things that tells us that it's going very well with the fetus or it's not going so well with the fetus. And that brings us then to the end of this lesson. And although this lesson was quite short, it is one of the most important lessons, and specifically when we come to the interpretation of the CTG. We need to use the 4 Ps with every single assessment and every single recording that we make on the Partograph. We should ask ourselves, how does this influence this specific P, the progress of labour? But we will discuss that in much more detail in the next lesson, in lesson 5. I hope you're going to enjoy your quiz. I hope you're going to pass it, and I'll see you in lesson 5 then.